So the background slide that we see here is a very familiar slide to all of us. But as with all important graphics, there's a story in these lines. First, we notice that there are two Okay. Perfect. So we're seeing this slide here. It's this common slide that we've been seeing in the media all for the last, as long as we've been watching any talk about this. And we see that there are two different slopes to this, right? We see starting in 2000 and clearly in 2014 and beyond, we see that the impact of death from the influx of inexpensive synthetic opioids that came into the market. And that has dramatically increased the rate of deaths from opioid use in the past years. But there's that first part of the graph, okay, that goes right up until we see the opioid, the fentanyl and other synthetic opioids coming to the market, that was still increasing, even though it was less of a rate. This increase was us prescribing opioid meds, okay? Now, this was accelerated near the end when heroin started to replace the more expensive the prescribed opioids that people were using. But in the end, the part of this graph that bothers me is that I was a part of it, okay? This is when I started in emergency medicine, and I remember a quarter century ago, as if it was yesterday, I remember, how many of us remember that campaign? Pain is the fifth vital sign, all right? That was so important. So it's true, pain is very important, but we see the consequences today of half-truths, right? This was the age when it was drug companies and pharmaceutical companies that were coming in and giving you lunch and describing how important it was to treat pain and leaving off that other half of the story. The half of the story that had to do with what are the consequences of addiction, okay, and how addictive these medicines could be. So emergency medicine was a part of this problem, okay? And patients who subsequently died of substance abuse were frequently present in the emergency department. But we were just one part, as we all know, of the overall problem. And they received their pills, patients received their pills from many sources. And the EDs gave only about 5% of the opioid pain relievers in most communities. And they tended to prescribe smaller pill counts, lower strength, and more immediate release opioids. And while we accounted for 1.5% of the pills prescribed in the 12 months before their death, it was still hard for us to realize that we were still a part of this bigger problem. Now, New York City reflects this larger national trend, and this is the statistics from New York. But it's important to keep in mind that while New York City is not one of the per capita, we've fortunately avoided the top of that list of per capita deaths in this country. It still is a tremendous increase in deaths. And to put these 1,700 deaths in perspective, we have to realize that around 2017, that's combining the number of homicide deaths, about 300, suicide deaths, about 500, and even traffic-related deaths, around 900 together, is what is comparable to the 1,700 deaths that we saw related to opioid deaths in 2016, 2017. So, in the end, so the response to this, opioids in general, started with me, 2 decades ago, and it started, and it's still today, that same response that we all envisioned with opioids. It started with just responding. We just responded. And naloxone distribution from the ED is still sort of the mainstay of most emergency departments' response. And the rest of the talk will talk about beyond Narcan. But let's talk about naloxone. Now it's interesting. So naloxone was first patented in 1961. Okay? And what it was used for was initially used to treat constipation caused by chronic opioid use. It took a decade, 1971, before it was approved for the intravenous, intramuscular use. for opioid overdose. This 1970 is interesting because this is when my father first was doing his internship at Harlem Hospital in the early 70s. And even though frequently his stories would be prefaced by, I don't want you ever becoming a doctor, he would still tell the stories that clearly inspired me to become a physician. And one of the stories that he often that I remember very early on was as an intern, having an ambulance pull up with two patients in it that had both overdosed from heroin, but the door was locked and they couldn't get in. And my father says, I just took the medicine, I climbed through a window, and I gave them the medication. And he was severely chastised for it by his colleagues, like, how could you do such a thing? That was so dangerous. But the idea that you could save lives in an instant, in a minute, was so powerful. Now, the story that I have early on was a little different in that when I was as an intern, as a resident in emergency medicine, there was a lot of other combinations of things mixed with heroin in those late 90s. And one of the things we used to call is polo, was one of the things that we had. That was a scopolamine mixture with heroin. And the problem with that was you give the Narcan, and all of a sudden the patient would become uncontrollable. Just hyper, he would just start being violent and agitated. And we often had to intubate these patients just to get them to be controlled so that we could take care of them. Benzos were not enough, no matter how much we gave. But as we went on with these, and still the mainstay today of naloxone is, in the pre-hospital setting, it's giving Narcan. In the emergency department, it's continuing to give it in these boluses and drips, but managing these co-intoxicants. So often in emergency medicine, we actually will dilute even that small vial of intravenous with up to 10 cc's of saline and give a tenth of the dose, small increments, just enough to get them out of that breathing, so we can control their respirations, because these co-intoxicants still every once in a while will be very prominent. The real challenge that we had in emergency medicine with naloxone was, now that they're awake, what do you do, right? If you're concerned that they have taken a substance that could cause them to then go back into an intoxication and stop breathing again, do you just let them go right away? Naloxone has a very short half-life, around 30, 45 minutes at most, when it's worn off completely. In that time, if something now is still in their system, they could stop breathing again, especially methadone was a big component of that. So those were our issues. But the feeling of responsibility, even if the patient was awake, was limited to that hour or so when they could relapse. That's what we felt. That was the small spectrum of our care for these patients. The question is, how do we go beyond that? Options beyond naloxone. And this is a very recent phenomenon, options beyond naloxone. And this is what we're going to talk mostly about today. So the first thing I want to talk about is a story that's already on. I don't mind saying this story and sharing it with you because it's already been in Infinite, on the Infinite page. It's something that a story was done to promote something, a project that we were involved here at New York Presbyterian, and it involves Michael's story. Michael used heroin for the first time and went to lie down. His wife found him in their bedroom, his throat swelling, his lips turning blue, and she called 911. Paramedics revived Michael with 2 doses of naloxone as his 2 daughters, ages 3 and 4, peeked through the bedroom door. The next thing he remembers is waking up in the ambulance. Now, this is where our story usually ended. But now we've had another option. And since June of 2017, New York City Department of Health has a program called Relay. Relay is a program started by the Department of Health in response to the opioid crisis, and they said, we want to start this in areas where there are the epicenters of this crisis. Northern Manhattan, Southern Bronx were one of the areas, Staten Island was the other, and they decided to start here at New York Presbyterian. We were the inaugural site for this program because they wanted to say, how do we make this work practically? And so they started it here, and the program basically, if a patient arrives in your hospital and has been given naloxone, or if it's a suspected opioid overdose and they almost needed Narcan, but through some other bag valve mask or some other support they were able to not need it, then a Relay Wellness Advocate could be called immediately. We're talking 24 hours a day, 7 days a week. You just have to call, you actually call Poison Control, which is a 24-hour available line, and a wellness advocate from Relay would be dispatched to the ED within an hour. Now, we're still treating the patient for their medical. We're giving them Narcan if it's necessary. We're giving them when they're on a monitor. But what is this relay person then adding to this? Well, when they arrived, this is the person who would arrive in their blue jackets, which they wear, bless them, they wear them whether it's 100 degrees out or 40 degrees out. They're always coming in with the same blue jacket and this bag. And they come in and we introduce them to the patient. Now, often these advocates are people who have gone through substance abuse challenges in their lives in one form or another. And they come in, and when the patient is medically stabilized, which means they might wait for the patient. That patient could be still unconscious or waiting for their opioid, especially if it's methadone. It could be hours sometimes. They'll wait in the waiting room until that person wakes up. Okay. Well, when the patient wakes up and stabilized, then we approach the patient. You know, we have this experience here in the emergency department. They can come and talk with you about reducing the risk of overdoses, can teach you about naloxone. And they have these care bags, and they have food, water, there's even a Metro card in there. Would you be willing to speak to them now? And that, hopefully, that connection, that relationship that's made is very special, because it's not just about the bag, all right? Because upon discharge, these wellness advocates will continue to engage with patients to provide ongoing support and linkage to care for up to 90 days, okay? And his story, Michael's story continued, is what we see. During the 90 days that Ben, who was the advocate who came in, and Michael worked together, they decided what he needed most, Michael says, was someone to listen. They met weekly at a fast food restaurant to talk, and if I was having a bad day, I would just let him know and tell him what's going on. And he would give me advice and just talk to me because I had a lot going on. Ben felt easy to confide in. You're doing good. Stay focused. And that was good motivation. And the story continues with getting him into programs, not just about drug rehab, but cooking school, because that was one of the interests he had. Getting him into programs that could find him a job, find him training to get into a job. These are the things that the advocate could continue doing for 3 months. To say that the relay intervention has expanded to even more hospitals. They're in the Bronx. We've expanded obviously to our Allen Hospital, and it's up to 7 sites. They've, as of January of this year, they have up to 750 interactions. In Millscene alone, it's 130. Here, it's 40 at the Allen, with over 250 kits being distributed not only to patients but also to their family members as well, which is why there are more kits. So this is something that has been a tremendous success here at New York Presbyterian. We're hoping to expand it even more. And there's even plans to actually do a CDC-sponsored study to actually look at that the act of coming in 24/7 and making that connection right there in the emergency department. Hopefully at the moment that they're most willing to change. Now they have just almost died. If there's any moment where someone is willing to change, we're hoping that this is the moment. That intervention, how much does that intervention help over these other services, which I'm going to go to describe next, could also be provided that don't require, because that's a pretty labor-intensive intervention, right? 24/7 availability on the spot. So community-based organizations is the next type of intervention, because right now Relay is only open to those patients, available to the patients who are near-death experiences. So what about the other patient? This is someone who's clearly at risk for overdose. They're IV drug users, but they're coming in that day for withdrawal, or they're coming in that day because of an infection at an injection site. Unfortunately, Relay right now is not prepared to handle that, but there are other resources that are available. So community-based organizations, the next big resource that we're bringing into the emergency department. And these are organizations that come into the emergency department not quite 24/7, but 9 to 5, with the ability that overnight you're giving them a message or sending to them, we have processes developed where they will say next business day, this was a person who was in the emergency department, and they can contact the patient and assess whether they are qualified for one of these treatment programs, either medically assisted treatment, which we're going to go into in a little while, as well as just any number of rehab programs. So there's still challenges with these community-based organizations and the emergency department that we're dealing with on an ongoing basis. For example, there are many community-based organizations. There are so many and now more and more that are growing. And how do you coordinate that? How do you say which is the one we're going to call for this patient? because they have other issues as well. It's not just opioid. They also have psychiatric, or they may have alcohol, or they may have other. And there's some organizations that are better suited for one or the other. You can't have emergency physicians. None of us as physicians could learn all of these options. So how do you find a place that you can simply call that then can sort out these issues? And especially because many of these organizations have very time-intensive screening processes. Because there's sometimes insurance issues, other times it's have they been in rehab before, what resources do they have? These have to be evaluated. And then the next question is, do you have them come to the emergency department? Do you have a space carved out in the emergency department for these staff or not? So the next thing that was interesting for us was medically assisted therapy. How many people here have X waivers, gotten their X waivers? Actually, because I actually have, all right? And it was the first time it was brought up, should emergency physicians do the training, which is an 8-hour training, in order to get the ability to prescribe one of these medically assisted therapy medications, mainly buprenorphine or Suboxone, which is a version of it, to patients in the emergency department. First time we brought this up, no way, why would we be in this business in the emergency department? But it's been interesting. We've actually had a large study, a major study that came out in 2015, an emergency department-initiated buprenorphine naloxone treatment for the opioid dependent. It was a randomized trial, about 300 or so patients, about 330, 110 to 3 different arms. And the arm that had, the question was if giving them buprenorphine in the emergency department made a difference in the follow-up. Because you either gave them buprenorphine and then did whatever you could to get them into rehab, into treatment programs. You just gave them information about treatment programs, or you did nothing, okay? And in that study, if you gave them buprenorphine in the emergency department as a bridge to a program, you had doubled the number of patients by the 3 to 6 month follow-up that were still in programs. You had less illicit drug use in that group, and you had that with less inpatient admissions in that time period. So this was pretty dramatic in this one study out of Yale. And the question was, if this could be reproduced in New York City, or any large city, what kind of impact would we see? So we've been convinced in the emergency department, and we actually are having a lot of on-site training programs that we are encouraging as many emergency physicians. First, it started mostly in the psychiatric emergency department, but now it's expanded to even the medical side of the emergency department, where more of our physicians are getting this X waiver. Okay. So the challenges with this is the training. 8 hours is a long time, especially if but there are ways where it actually is a little less. These programs are more and more being tailored for physicians, and while you can split that 8 hours to 4 hours in person, you go to an afternoon session, and then the rest can be done online at your convenience. And that helps a lot. And the process for me was very easy. I just got my X certificate literally in the mail last week. And it was once you go through that course, you take a very quick quiz after you go through some quick modules online. And as long as you pass that, you get your waiver. At that point, any pharmacy will accept your prescription for, in this country, it's buprenorphine, it's Suboxone, which is a combination of buprenorphine and naloxone. One of the challenges in the emergency department is this idea of when you start naloxone, one of the things about starting this buprenorphine is you can't give it to someone who's not in withdrawal. It's not dangerous. The problem is that unless someone is already in moderate to severe withdrawal, if you're in that stage, I'm in moderate withdrawal, I'm feeling sick, you give them the first dose, which is a sublingual dissolving medication, they feel better, and now they're like, this is something I want to continue. The problem is if you start with someone who's actively intoxicated or just even in mild withdrawal, the pharmacokinetics of what you're dealing with means that they actually go through some withdrawal symptoms right away. They feel all of a sudden very ill, very sick. And if that's their first encounter with this medication, the chance they're going to continue it is diminished significantly. It's not dangerous, it's just that they feel sick, and that the whole point is to encourage them. So this is a challenge because it can take hours sometimes for patients to start having withdrawal symptoms. What's interesting is that since the study came out, and people have gone through in outpatient settings, they have 4, 6, 8 hour protocols. When we realized that we wanted to do this in the emergency department, we realized that that was too long. Could we do it differently? And actually, very successfully, programs have realized that patients, especially patients using heroin and street drugs, often experience withdrawal all the time. I mean, this is something they're very expert on when I'm in withdrawal. And they try to avoid it, they do what they can to avoid it, but they know it. And there's been tremendous success in telling patients, you know when you're in moderate withdrawal, I'm going to give you the prescription. When you have your withdrawal symptoms, take your first medication. And there's tremendous success with even that. Patients are able to do this, okay? So we're learning to see different methods to try to get this implemented in the emergency room without impacting on length of stay and having patients take up a lot of resources in the emergency room, but still huge impact when they leave. The most important thing when you start this medicine, we're not doing this to keep patients on for 30 days, 60 days. We're doing it for 3 days to get them to a program. And just literally in the last year, it has gone from, we can't find a program for this patient. It took us days to figure it out. In the last months, the number of programs in this community have expanded significantly. Right now, there should be no barrier to getting any patient into an outpatient medically assisted therapy program in this community. So if you have a patient, you should be able to find that resource. So this is the end. I'm going to be very quick. I just wanted to talk about, and then before I go on to this, what is the potential impact? Now, France is an interesting model. Now, it's true that of all the prescribed opioids in the world, the US prescribes about half of them. Okay? That is what the US does. So, but France actually dealt with their opioid crisis, which was mostly heroin when they dealt, but in the 90s, both a combination of drug-related heroin use that, just as we saw in this country, that it evolved a little later, we were aware of a little later. And they recognized this in the 90s. They started this and became very liberal in trying to get access to medically assisted therapy and getting buprenorphine or Suboxone into the hands of primary care physicians throughout the country. And in France, the number of opioid deaths was reduced 90%. It is a tenth of what it was when they realized the height of their problem. So a country's mobilization to do this is possible. And it's going to take more than the emergency department. It is also going to take primary physicians. Suboxone is going through the course unbelievably. The therapeutic index, the safety profile of this medication is huge. It is hard to cause problems with this medication. As I said before, our biggest concern is that you're going to just make someone sick rather than feeling well with that early dose, and it's going to discourage them. You're not risking respiratory depression. You're not risking even this concept of addiction because it doesn't have that same euphoria. All of these things are off the table. It is a safe drug to give, as we're realizing we can do this as an outpatient. We can tell patients, start this medicine on your own, and it works very safely in study after study. So this is a safe medicine. As you get to hear more about buprenorphine, as you hear more about Suboxone, please lower your threshold, if at all possible, for saying, how can I be a part of it? Because if I can prescribe it, you're not going to see a downside. You're only going to see a positive. Trust me on this, okay? So, lastly, I just want to talk a little bit about the evolving role of myself in ED administration. I came out of residency program in '98, came right here, and was hired as an administrator right out of the bat. That's because there were not a lot of emergency medicine programs at the time. And so I was assistant site director here in '98. And ever since then, gone through various roles, as they mentioned earlier, covering QA, administration. And there was a theme to all those, right? We were always concerned about the process and performance within the emergency department. What do we do? How do we take care of this patient? Do we give them the right meds? Do we have a problem with the diagnosis? It was all about that's the focus. And that consumed all of our time, and we were happy to do that. But then we started realizing, the first thing we realized about a decade or so ago, is we started realizing that we had to also look now at, we're admitting a lot of patients to the emergency room, from the emergency room to the hospital. Are there borderline? Are there cases that if they had just some other resource, some other thing that they could do, they don't necessarily have to be admitted to the hospital? So this idea of services, alternatives to hospital admission, was one of the big category of early projects that I was involved in. And they had some limited success, but things like DNS and Jewish, these programs that that tried to say, oh, if you can give these services to a patient, you might not have to admit them. And we're still doing that, and preventing admissions is still a big part of it. One of the big initiatives that we have right now is just getting people into appointments. So we have this Navigator program now, where we are very aggressive, similar to almost to what you saw with Relay. A navigator is not just someone who schedules an appointment anymore. We have a large group of people, dozens of people, who are dedicated to this. When you say, this is a person who will have a barrier to getting their next appointment, either because their diagnosis is a little sicker, or they're underinsured, or whatever the reason, we go to them and we say, we need you to help us get this appointment in the next week or two. So they say, fine, and they have access to appointments, but what they're also doing is, hi, I'm your navigator. This is my name. This is my number. What's your number? And then they say to them, oh, you need a specialty service within a week. That's hard to get, and we all know how hard it is to get specialty services. But what we can do is the navigator will say, no problem. They'll call the clinic and say, are you having any cancellations tomorrow? The next day, do you have any cancellations tomorrow? And then, oh, you have a cancellation? I have a patient for that spot. We put that patient in, I'll call the patient, let them know that now they have an appointment, and they're able to get patients into our no-show rate in a much better way. We have gone, with our Navigator program, to having this we now are so confident that patients will get the follow-up we ask them to, that it has reduced our admission rate to our hospital over the last 5, 6, 7 years, even though it's been around a little longer than that. But we've become just so much confident. And our follow-up rate has gone from what was a national average, when you just tell the person who was didn't have a doctor, was underinsured, you said, call this number, or even here, this is an appointment for 2 weeks, show up. The follow-up rate was actually at a national level, about a third of those patients actually made it to that appointment. Now with the Navigator program, it's well over 70%. It's 70 to 80% of the patients make it to their follow-up. So those are the things that we do with that extra relationship. And then now, in addition to services to help for hospital admissions, we are looking at how do we reduce ED visits. And the caveat to that, the one thing that's interesting is people always add this extra word, which is hard to do. How do we reduce unnecessary ED visits? That's a surprisingly hard thing to establish. What is unnecessary and what is necessary? But that's my project. That's been a large part of our goals. And one of the things that's an naloxone project that the MAT program is trying to do is keep that patient from having to come back to the emergency department. So the future, better coordination with you, community physicians, with better emergency health record interfaces, telemedicine, as was mentioned earlier. There are many opportunities for that to help us in this communication, so that we can try to, if you're recognizing patients who are at risk for opioid overdose, and having conversations earlier on, so it's not just the patient who comes in near death, but a patient who's just at risk, and having coordination, because sometimes, of course, patients use EDs as an escape valve, and how do we prevent that from being inappropriately done? And then in coordination with home care services, community-based organization, and these health navigators, as I mentioned, we try to get patients of all types into the system. That's it. Questions? We'll call.